challenging cross-cutting issues like quality, gender equity, and are specifically tailored to the needs of respective communities. The TRP observations provides us with very sobering observations, yet I'm not completely surprised by them, and I'm sure you are not either. Findings from its window 1 and 2 review of funding requests noted just how important it has become to significantly increase the attention and investments in both community system strengthening and RSSH. It really provides us with a sobering assessment that community system strengthening is not yet well understood by several of the applicants, including communities and CCMs and decision makers, which results in a very ad hoc and inadequately funded CSS intervention package that's eventually funded within grants and really struggle to result in impact. In 2017-19 funding cycle, the Global Fund invested roughly $111 million in community system strengthening, of which around 24% were for community-led monitoring interventions. Even though this is a promising observation, CSS still remains largely conflated with community health workers, which results in funding requests really being skewed and not really prioritizing resources for effective programs for and led by key and vulnerable populations. We've seen remarkable results from West and Central Africa through the Global Fund supported treatment observatories that showed us a reduction in frequency of stockouts and increased rates of viral load suppression. Similarly, in Sierra Leone, there were persistent challenges in the implementation of an effective TB program. And then advocacy led by communities, informed by community-led monitoring data around drug stockouts and the availability of TB drugs at facilities has resulted in more expedited drug supplies and efforts to create more TB sites in response to long travel times, which makes accessing these services and treatments more difficult. In Indonesia, peer-led tracking of loss to follow-up of people living with HIV has contributed towards direct improvements of retention rates amongst clients on ART. And health officials even adopted this model since it provided vital information on why people stop taking the ART and drop out of care. As a CRG advisor, I'm very fortunate to be part of the process of reviewing funding requests. And so it allows me a window to see new, innovative, and really remarkably ambitious interventions related to community-led monitoring that's included in funding requests. And this ranges, as you know, from mystery clients of sex workers to AGYW champions, quality monitoring in transition contexts around harm reduction and HIV prevention services, but also really thinking about positioning community-led monitoring as integral to, for example, the Zero Malaria Starts With Me initiative, led by the RBM partnership in Senegal and Kenya. But yet it's not, we still have a lot of work ahead of us, and now is not the time for complacency. We continue seeing the lack of understanding of CSS and more specifically CLM, both within the Secretariat and amongst external stakeholders themselves. Community-led data is often viewed as non-robust or technically valid, which results in poor acknowledgement of these lived experiences and challenges to drive responsive programming, while at the same time recognizes that data from communities is really critical and vital to reaching the last mile and bending the curve, or whatever you want to call it. And so we continue to see the need for improved relationships between communities and decision makers to really drive change, both in the short and in the long term. I'm also happy to just quickly reflect on the community-led strategic initiative that Gemma alluded to earlier. The SI is meant to provide technical support that's very tailored and quite long-term to strengthen and increase the uptake of community-led monitoring mechanisms and models in their variety and amongst their diversity. In addition to the SI from the community-led monitoring, which will focus on several countries, and I'm happy to share more information about that. There's also conversations with the CCM Evolution Strategic Initiative, which includes a focus on using CLM data for CCM oversight committees to really think about how do we drive change and achieve our goals on human rights violations, user fees, stockouts, program quality, and so on. So the work that lies ahead is to establish links with existing mechanisms on community-led monitoring and to think about how do we develop pathways for information to flow routinely to CCMs and for CCM to use this information for timely improvement in programs. Finally, I'm also excited really to share with you that we are working very closely with UNAIDS on community-led monitoring support and the technical assistance packages that are available to strengthen the uptake and use of CLM. So doing so really make sure that we are synergistic and complementary in our support instead of trying to spread ourselves too thin, but at the same time that we are strategically focused and non-duplicative. It's also an opportunity to share tools and lessons from respective support countries while maintaining very open communication with both service providers and donors alike. So all of this said, it would not have been possible to get this far in community-led monitoring without the thought leadership and actions from civil society and communities. And I'm very, very excited about this practical guide and would like to congratulate IANASO and Frontline AIDS and GIZ Backup and the Stop TB Partnership and the Community Rights and Gender Coordinating platforms for paving the way for us and providing this much needed practical guidance across 3 diseases on CLM. I'm very proud to be here today and to share in this moment. Thank you so much.
Thank you so much, Kate. I think those have been really very nice words and quite a lot of information there that's quite very useful and beneficial for this discussion today. So as we progress forward, we just want to have a short moment of reflection of what actually has been happening with regards to CLM in different contexts, just to set the ground for our next stages. And we just want to hear a couple of experiences and challenges, designing and integrating or implementing CLM experiences from a malaria constituency perspective. And I want to call upon Ayo. And I have 3 speakers for this section, and I'm going to be giving them 10 minutes each. Actually, just keep it to 10 minutes, guys, because we don't have much time. So I want to call upon Ayo to give us a community experience on malaria from Nigeria. Ayo, please take the floor, and your 10 minutes actually starts now.
Okay, good afternoon, colleagues.
Good afternoon.
Thank you for having me. My name is Ayo from a member of the General Committee of CSLA. As has been said, Akumi is implementing the community-led monitoring.
You're breaking so much, Ayo. We can hardly hear you. Probably if you can get some good network connection.
Malaria in Nigeria, 2nd year of the.
Ayo, you're breaking so much. Do you want us to probably go to the next speaker as you try to check the connection of your internet?
Okay, you cannot hear me.
Yeah,
Hello?
you're breaking so much, you can hardly follow. If you want us, probably we could go to the next speaker, and then we can check if after the 2 speakers have spoken, if your internet shall have improved. Is that okay, Ayo? Hi, Ayo, do you hear me? Okay, I think we will go to the next speaker, and then we will get back to Ayo after the two speakers have presented. So if
Okay, good. Go to the next speaker.
Okay, if we can go to Maxim. Maxim, please, if you can take the floor, your 10 minutes, so that we can share your experience on the TB from DR Congo.
Thanks, Lewa, for giving the floor. First of all, I thank Yanaso and all partners who organized this webinar that is giving us the opportunity to share our experience of community-led monitoring in GRC. I can have the presentation.
One is pulling on your presentation up. Roderick, if you can pull on Maxim's presentation, please.
So I'm Maxim Lunga from DRC. I'm responsible of TB survivor organization named Club des Amis d'Amiens. And you take my minutes. I see that I have only 10 minutes. Where is my presentation?
I think we can give you the permission to just do your, oh, it's here. You can see it now?
Yes.
Okay, perfect.
Yes. So I said that I will share with you our experience based on one impact, community-led monitoring, protecting and promoting the rights of people affected by TB conducted in 2019 by Club des Amis d'Amiens in DRC. Next slide. This project is part of the Global Fund strategic initiative to fund missing people with TB, which is organized with USAID. In terms of the definition, community-led monitoring is the engagement and empowerment of people affected by TB, preventing them from being diagnosed and successfully treated for a rights-based, people-centered, accountable, and equitable TB response. We have the objectives distributed in 4 levels. For the patient level, the objective is to empower people affected by TB to know and claim their rights and to engage in the TB response. And the monitoring, surveillance, and advocacy level to generate data on human rights barrier to boost the TB monitoring and evaluation system. And also to generate information on human rights barriers for evidence-based advocacy. For the community level, to build the community capacity to engage in the TB response and to identify and resolve problems at the local level. The problem is related to the gender and human rights barriers. And for the programmatic management and TB innovations in health system level, we have the availability, accessibility, to evaluate the availability, accessibility, acceptability, and quality of TB services. This is all for the right to health. Next slide. To monitor the community-led monitoring, we ask the following questions, distributed by availability, accessibility, acceptability, and quality. For availability, the question is, do the required TB health facility and service exist and in efficient quantity. And acceptability, are the TB health facility good and service physically, geographically, socially, and economically accessible? And for the acceptability, are the TB facilities good and services respectful of medical ethics and cultural appropriate and sensitive to the needs of different genders? And of the quality, are the TB health facility good and services scientifically and medically appropriate and convenient? And to follow the implementation, we followed the implementation phases recommended by Global Fund and W to implement the SLM in DRC. We begin with the inception and multi-sectoral meeting. We bring all of stakeholders in the fight against TB in DRC to do the inception phase and also to adapt the One Impact from digital framework in the context of DRC. And then we select the community members and the TB patients who can use the application in the health facilities. And then we do the training and the launch, the One Impact, which named One Impact TB Tolongi for us. And after the training, we launch the implementation, and we follow with the monitoring and evaluation framework from Stop TB Partnership to collect the data. And this collection period was that July to December, not 2020, but 2019. Next slide. Next slide, please. Next slide, please. Do you hear me? Lewa?
Yes, we can hear you.
Yes, next slide, please.
Yeah, we hear you. The machine that we are using to roll the slides
hanging. Yeah, we can hear you, but since it's hanging. Okay, now.
Yes. Okay, that's the slide. Yes. To use the community-led monitoring partnership One Impact digital platform in the context of the country, and this One Impact digital platform, which has 3 models. The first model is to promote the objective to people-centered rights-based care with 4 components that you can see. The knowledgeable, get access, is to find the health facilities near you, and get connected to do the community forum, and the get involved. The get involved is the component that can help the app users to report the problems. And the second model is for the first responders, when people affected by TB reported barriers, and the community health workers can see and coordinate response in the accountable dashboard. It aggregates data on availability, acceptability, accessibility, and quality, for that community can use this information for advocacy and an action program for programmatic decision making. Next. In the term of key results, by 4 objectives that we have. 3, and how to claim their rights, leveraging the Declaration of the Right of People Affected by TB. And at the level of community system, 365 people with TB oriented on and how to claim their rights. And we have 25 people with TB engaged to identify barrier to access and design the application. 177 people with TB actively monitored the TB response. And community-led monitoring data shared with these people identified priority areas for advocacy and action. And we had 60 people of Club des Amis d'Amiens formally engaged in responding to barriers to access, enhancing accountability at a local level. And we have the creation of okay. And then please, you can go back to the last slide, please. No. Before this one. Yes, here. In the monitoring, no. Next, please. Yes. On the monitoring, surveillance, and advocacy level, availability of evidence on human rights barrier for the first time. We have the data for the first time in the real time in DRC relating to the rights barrier. 46% of the people with TB reported a barrier at last one over a 6 months period against the acceptability, availability, accessibility, and quality framework. And we have 59% for the barrier reported for the quality of TB services. Identification on the major barrier to access, which informed the Global Fund funding requests. NMF3, availability of data at monthly health meeting and the potential integrated with DHSD here in DRC, that is the electronic system, data system on the health system. And the programmatic management of TB and innovation, availability of innovative digital accountability platform which collects real-time data on human rights barrier for the first time, availability of data on human rights barrier in real time for more efficient response to barrier for the first time, and identification on the major barrier to access, which evidence for the first time also. Next, please. Yes, you can see the graphics here. For the quality, say they use the community-led monitoring data and on drug side effects to develop a protocol with the National TB Program on managing side effects in an efficient manner using a combined. And on accessibility, SEADE is working with the National TB Program to make sure that people can access to the nearest health facility. On the availability, SEADE uses the community-led monitoring data on stock with the National TB Program to agree to receive, and as agreed to receive. And for the reported, SEADE uses the community-led monitoring data on stigma to advocate for the inclusion of the TB stigma assessment in the Global Fund funding request. Next slide.
Okay, time is running out. If you can fast track your presentation, please. Your 10 minutes are over.
Yes, is the last slide on lesson learned. But you can see that on the people affected by TB level, they said that a human rights-based approach should be the central objective of community-led monitoring, but we must include other rights. For example, the right not to be confidentiality, and the right to freedom from discrimination. They said also more information on people affected by TB should be included in the application. And they want to connect as a group and not just as individual in one impact. And people affected by TB need to know how long it will take for problem to be resolved to avoid multiple reporting. And the community members have said that inbox should be easy to use, and a data validation protocol must be in place to say what response we can give for which first responder should know the response protocol for each problem. And the health workers say that the formal health system should be engaged in finalizing the response protocol and analysis and the use of the data. And now, since this year, 2020, we go the scale up of our experience to 2 provinces in Kinshasa and Congo Central with the challenge facility for civil society grant. And then next year, we think with the Global Fund of provinces, Nord Kivu, Ituri, Maniema, and Kasai. Thank you very much.
Thank you very much for that presentation. If people have questions, we are going to deal with that after all the presenters have actually finished. So if we can go to John Becko to give us a reflection on Zimbabwe integration of CLM. John, if you can come on, please, if you hear me.
Yes, I can hear you. Let me share my screen.
Sure, please.
Can you see the screen?
Yes, we can see the screen, very clear.
Okay. Okay, thank you. Thank you, Mleo and Yanaso, for this opportunity to share the my experience as a consultant on CLM in Zimbabwe. I will not take much of your time. I'll just go straight to what is striking me as a consultant and as a person who has worked with the communities for some time. The data source is actually my experience. This experience I'm sharing is based on the 2 processes that I participated in. One is the development of the funding request for Zimbabwe this year, early this year. And the other experience is also based on my support to the civil society in the development of the engagement framework that guides the relationship amongst civil society and community groups, as well as other external stakeholders. So these are the 2 sources of my experiences. And what I'm going to share this afternoon is based on these 2 experiences. Now, in terms of experience, is that there's an observation that CLM is becoming a bit popular, but this is limited at national level. So it's very, it is an in thing. Everybody wants to talk about it. But this is limited national level. So there's a lot of enthusiasm, a lot of people wanting to get scale up the engagement in CLM, but this is limited, as I mentioned, at national level. Then the new grant that I participated in actually has some allocation for contribute to CLM processes. The other observation is that there is actually documentation that is beginning to appear on CLM. If you go like 5 years back or 4 years or 3 years back, there will be really very little documentation on CLM. But currently there's a lot of talk and write-up is coming to appear, which is really good news, pointing in the right direction. The other observation is that the strategic plans are a bit silent on CLM. I don't know if this is, we may need to think about this. I don't know if this is good or maybe it's the design, how it's supposed to be. Maybe it's supposed to emanate from communities, pushed and led by communities at their level. So maybe not really necessarily need to have it at a very high level and planned, captured in strategic plans. So that's a conversation I think we may also need to have. Now, when it comes to specific to global fund processes, I think for those who have participated in the development of funding requests, you've noticed that The cross-cutting issues that touch on malaria, TB, and HIV, it's a bit difficult to consolidate these, mainly because the writers or the constituencies are different, and also during the writing, during the consultations, the process takes, it's actually operates in silos. So the TB will have their own processes and all that, and malaria and HIV. So for a person who has to integrate and consolidate community system strengthening issues across the three epidemics, it's not very straightforward. It can happen, but it's not very straightforward. That means CLM being part of a community system strengthening process, it gets affected by this nature of grant writing process. So that's another observation. So the issues that need to be captured that really makes sense for the malaria group may not be captured if the community system strengthening is embedded in the TB grant, TB HIV grant. So you can imagine how to come together and bring all these issues. The other observation is that all these conversations on CLM are at national level. So the big question is what kind of conversations should happen at really grassroots level. My experience in developing the civil society engagement framework is that when you start talking with community groups and community leaders at grassroots level or at devolved structures level, you really don't hear much of this of CLM. But it doesn't mean it doesn't happen. It's always happened at community level, but in terms of structuring it and improving it, you don't really hear the same conversation that we are having like today. But when you go to community groups at the grassroots level, these conversations are I think they are lacking. There's a gap. So that's my observation. Now, what these observations mean in terms of challenges on how to now integrate or bring CLM to an advanced stage. One of the challenges is that there's actually very limited knowledge, understanding on CLM. Now, maybe not understanding or maybe not knowledge, but if you ask people what CLM is, most people will give you different answers. And what their understanding is really different. There is actually some limited knowledge at national level, but at grassroots level, I think maybe the process happens, but not captured into text, not documented. So it's very difficult to understand what it means, the processes. Where do we draw the line between now community-led and the normal M&E monitoring and evaluation processes? Where do we draw the line? Who is involved in for it to mean community-led? So these are some of the gaps that we see in terms of knowledge and understanding of community-led monitoring. The other challenge that impact, I think, negatively is the lack of guidelines on CLM and its integration. So how, if we have a common understanding, we may not have a common understanding globally or regionally, but at a country level, if we have an understanding of what CLM is, then how do we ensure that it's integrated into our programs at community level? And what's the process? What are the some of the steps that we need to take to ensure it is fully integrated? So that's another, from my observation, is another challenge. There's very limited investments to support this kind of processes. And I think from the best of my knowledge, if you look at the Zimbabwe case, maybe it's GF and also maybe the USAID that have contributed to developing some sort of community-led monitoring processes and tools and systems. Yeah. So apart from these two major funding agencies, you don't really see other people, other institutions chipping in terms of investment. The other challenge is where are communities in these kinds of conversations? when we talk CLM, and really the people who implement it would uptake it and integrate it into their day-to-day lives is actually the community. And we've seen from the previous presenter how communities can observe and monitor quality of services at community level, monitor stockouts of health products at community level. These are the people who are going to do that. That's in essence a CLM. But where are these people? Where are these communities? My experience in Zimbabwe, I haven't seen at a really lower level, grassroots level, community groups, any kind of organization, social organization at grassroots level being involved in this kind of conversation. So the question is, are the communities left behind in terms of this conversation? And if yes, what are the implications when when everybody is now trying to implement CLM? So how do we get these communities buy-in, ownership, and all that? The other challenge is the CLM. My observation with the processes is always led by development partners, civil society groups at national level, technical partners, UNAIDS will contribute to that, this kind of discussion, put in funding, for example, and all that. So, but does this mean it's community-led again? So that raised that question. Is it now community-led? So is Global Fund providing the policies or advice or guidelines, or other partners chipping in terms of funding? Does it still retain the community-led aspect of CLM? So these are the big questions. That's my observation. If you go to the grassroots level today, it will be another tool. A community member who will implement CLM will look at it as another tool coming from national level governments or development partners at global level. They wouldn't see it as an initiative that it's community-led. And now this brings into the very key question that I keep on asking, that as a consultant, that the moment a funding or support program country ends of CM as well. Because I mean, this is coming from the community volunteers integrate this process and use this process because it's funded, and we were told to do this. So once the grant ends, it ends. There's a stop. But as part of community system strengthening component, there shouldn't be a stop. There shouldn't be an end. This is something that should be part of life for the community volunteers, for the workers at community level, for the community itself and the community leadership. This should be part of life and should be something that is sustainable and can be their way of doing business. So that's one challenge I think we also observed. And also the role.
Our time is running.
Thanks, thank you. So the role of who does what in developing the CLM is very important. Who is funding it? What are the technical inputs? Who is doing that? Who is doing the rollout? Who is doing the implementation? And how is the sustainability going to happen? So that's another issue that we need to monitor, observe. And with that, I think I come to the end of my presentation in terms of sharing experiences in Zimbabwe on CLM. Thank you.
Thank you very much. Thank you very much, John. Are you now visible, available? Did you get some space that your network is stable? We can have 5 minutes, Ayo, if you now have stable network.
Okay, I'm here. Can you hear me?
Yes, we can hear you very well. Please keep it to 5 minutes. Time yourself.
Okay, all right. Please go to number 2 slide. Well, Akumi, which is the civil society network on malaria, immunization, and nutrition in Nigeria, we're engaged on the community monitoring-led component for malaria. We started this in 2019, and this is our 2nd year. Let me say upfront that This was developed solely by the civil society in Nigeria. And so it's our project, and though we are funded by Global Fund, but all the elements are developed by us. Now, we have 4 areas of focus for the CLM. One is commodity utilization, and for that, we are focused on keeping the communities accountable. Many a times when we talk of accountability, we are thinking in terms of the government, civil society and community to government. But we started from keeping ourselves accountable first, knowing that accountability is a two-way street. And one of the problems we have been having in malaria is that communities do not utilize the long-lasting insecticidal treated nets for sleeping inside. Rather, it's being used for so many different purposes, for farming, for fishing, for clothing. So we always start from that. The communities have to use the nets for the right purposes. Otherwise, all the work that we are doing is not going to achieve success. We focus on value for money. The funding that Global Fund is putting, is it achieving results? We focus on budgetary appropriations. That goes to our local governments, particularly the local government and state governments, for domestic resourcing. We are trying to see that we are not totally dependent on partners going forward. Our state and local governments also have to put money in malaria. And that's where we can begin to ensure sustainability. And then human resource development to be sure that the government, the local government, are deploying appropriate staff to the facilities. Let's move forward. Now, let's move forward. We have 3 objectives. One, we conduct strategic monitoring activities to hold communities first, as explained, primary healthcare centers, local governments, and all relevant stakeholders accountable for service provision and results. Number 2, to engage in sustained, measurable advocacy efforts for improved state and local government support, then to improve coordination of civil society and community structures. Let me quickly speak to this because I do not have time. I've spoken to the number 1, the community monitoring aspect, but you will see that what we do in our design is that when we conduct monitoring activities, any issues that we observe that are not functional, for instance, at the primary health care, we find out that they do not have staff. We do not write reports and send to Global Fund. What we do is turn it into advocacy issues and engage with the agencies of government that are supposed to provide the staff. So we are bringing solutions. Now, this is the structure of our project. The CLM is community-led, and we are broken into teams. We call those teams the community accountability teams. Each team is made up of 3 persons. 1 from the community-based organization, the NGO, the second person from the World Development Committee, and the third person, a nominee of the traditional leadership of the community. We are working now and trying to institute things into the traditional communities. 50, 100 years from now, the communities will hopefully be there. So if they take on what we are saying, then we are talking about sustainability. The teams, the community accountability teams, are equipped with tools. The tools are both technology-based tools and paper-based. And it's these tools that they use in targeting the focuses of accountability and monitoring, the primary healthcare, the government, and the communities. Then, as I said earlier, at that level, the local government, with each community accountability team, also function as the first level of advocacy team. And at the state level, we have a state advocacy team. Issues that could not be resolved by the team at the local level is brought up to the state level. And the state accountability advocacy team engages with the state government to resolve issues. Let's move forward. In Nigeria, Global Fund is implementing malaria in 13 states. And we're implementing this community-led monitoring in those 13 states. We have a total of 195 community-based organizations that are implementing this in the 13 states. And each community-based organization is working with a team that's made of 3 persons plus the executive director of the NGO. The key activities that are held in the one, the focus group discussion, that focuses on the community. Through the focus group, we find out what are the opinions, what are the views of the community on service provision in the on malaria. We have the second one is the client exit interview, where we interview clients who actually came to receive services and to know whether they are satisfied or not with the service they are receiving. The third one is the key informant interview, which is held with the staff of the local government and the primary health care to know also from their perspective the services they are rendering, whether they have the tools that they need. So when we have information from these 3, we triangulate, and from here we have a clear picture. We have from the staff of the government, key informant interview, from the service receivers, the clients, and then from the communities. Now from the interviews and all the work that we do using our tools, the issues that come up are turned into advocacy. Let's move forward. Now, these are our indicators. I said, what we are doing is not just to find out what is wrong. We find out what is wrong, and then we bring remediation. We bring correction through advocacy. So the indicators we report on are the number of issues we identify. For instance, whether we have staff, whether the nets are being supplied to the primary health care, whether the primary health care buildings even exist at all. You know, so many different issues that could be found out. Number 2 is the percentage of remedial actions successfully undertaken based on the feedback received. So like I said, our teams work in a holistic basis. They do not just go to the community to find out what is not working. They find out what is not working, and then they take remedial action through advocacy. The advocacy targets are the government and the communities and partners. The third indicator is the number of advocacy issues pursued by the teams. Then number 4, number of media coverage and publication of global fund malaria activities. Let me quickly say this. I did say that we have the state advocacy team. Part of that team is the mass media. We have woven the mass media into the core of what we do, so that the electronic and the print media see themselves at that state level as part and parcel of what we are doing. We do not need to pay them to report the news. So when we go for advocacy, when we go down to the communities, we go together. So they are reporting. We have now improved the reportage on malaria activities in these 13 states through the mass media, and we are covering that with one of the indicators that we decided. The number of media coverage that we have, the number of commitments made by decision makers. When we carry out advocacy, we extract decisions from the government at the state level, from the government at the local government level, and also from the leaders at the community level. So we tally that. Number 6 is percentage of issues resolved. So when we have the commitment, how many of them actually were resolved? Let's move on.
We have done our 10 minutes, Ayo. If you can just sum up.
Okay, this is the last slide.
Okay.
Okay, that's all right. Thank you. Okay, the last slide. Thank you. Yeah, well, I've spoken to this, but let me just say one of the things that we have seen is when the communities are engaged and empowered, they actually make things easier. And we as civil society, if we are talking about sustainability, what we should do is go community. Communities actually open the door and they make things work better and faster. Thank you. I stop here.
Thank you very much, Ayo. If people have any questions, please feel free to drop your question on the chat box, I can see as people are dropping questions on the chat box, already their responses being provided. So feel free to use that facility. We will move on to Rhoda, and then we will have a whole session of question and answer. So if you have any questions for any of the presenters, please just keep it put. Once Rhoda has finished doing our presentations, then we'll actually be doing a whole round of question and answer. So I would wish now to welcome Rhoda. Rhoda, welcome, and actually take us through the first session, which is on conceptualizing and designing and implementing CLM mechanisms. Rhoda Lewa, welcome.
Hi, everybody.
Hi, Rhoda.
Can you see my screen?
Yes, we can.
Yes, you are loud and clear. We can hear you.
Thank you very much. As mentioned by Mulewa,
as well.
As mentioned by Mulewa, I am Rhoda Lewa. I'm an independent consultant based in Nairobi, Kenya. Happy to have been part of the process. I have been happy to have been the lead consultant in the development of this guide that will be launched today. In this session, I'm just going to highlight for you briefly the process of conceptualizing, designing, and implementing CLM mechanisms. Briefly, I thought it's important to just reflect briefly on how the Global Fund defines CLM, which is mechanisms that service users or local communities use to gather.
Rhoda, full screen, please.
Sorry?
Rhoda, full screen, please.
Okay, let me try. Okay, just a minute. Better?
That's okay, Rhoda. It's on full screen.
Okay, mechanisms that service users or local communities use to gather, analyze, and use information on an ongoing basis to improve access, quality, and impact of services, and to hold service providers and decision makers to account. So that's the thrust of community-led monitoring. And when designing, when conceptualizing and designing a CLM mechanism, it's very, very important to actually invest a lot of time on this stage, because if you don't get it right, then the probability of you succeeding in your CLM is very, very thin. Basically, at this stage of conceptualization, you should be able to close your eyes and actually see the end from the beginning. You should be able to see the stages. You should be able to answer a number of questions about CLM, some of which I will briefly discuss, but as well as you can also review on the guide that will be shared after. The conceptualization process is a collective and participatory process. I recall John in his presentation saying the conversation around CLM is mostly a national level conversation based on his experience in Zimbabwe. That should not be so. In terms of conceptualization, design, and even implementation, CLM is actually a grassroots intervention which brings together service users who are basically communities. And when I say communities, actually imply communities of people who are living or are directly affected by diseases, who need maybe treatment commodities, but also those who consume prevention commodities, including key and affected populations, as well as just service users and beneficiaries. Yeah, just to add, if you don't conceptualize well, then there's a big probability that you will under resource your CLM intervention, and that means that your implementation, you will be busy implementing, but busy fundraising for emerging needs that you are not able to have thought through at the beginning. And the end product of conceptualization and design is actually an implementation ready CLM mechanism. And the conceptualization and design process is actually 9 steps, and I'm going to spend a little time just walking you through the 9 steps. So to start with, I'll focus on the 8 steps. And the first of the 8 steps is the community empowerment phase. As aforementioned, CLM brings together communities as well as service providers together. And when I was reviewing some of the comments in the chat box, I think it was my colleague actually, Salome from Uganda, who actually said communities have been doing CLM for a long time without them knowing that they are doing communities have been doing CLM for a long time without them knowing that they are doing CLM. So what really is community empowerment phase? It's about bringing the service users on board as far as CLM is concerned, to make them understand this new term, which is labeled CLM, and some people are using CBM, but for us, we have focused on CLM. What is it? For government and even civil society who are service providers, what is CLM? Is it an inspectorate kind of approach, fault finding? Or is it just empowering a community person to be able to say, excuse me, something is not going right as far as accessibility of services is concerned? Something is not going right about availability of commodities. Something is not right because as a KP, I get my medicines, treatment medicines on one venue, and then I get my condoms from another location, and then I get my lubricants from another location. The time and out-of-pocket cost is too huge. So it's about empowering all the stakeholders for them to have a good understanding of what CLM is, and that it's okay to actually voice and say something is not right here, and a remedial action needs to be undertaken in order for improvement in access and quality of services, which then will translate to improved service delivery, which then will translate to saving more lives and reduction. You know, you can actually connect it to the national goals and as well as to the goals of the objectives of the Global Fund, that is to save lives. So that is the community empowerment phase, and it's actually a foundation phase for conceptualization and design. The next stage is the planning and conceptualization, and this is actually where you were referring to that you should see the end from the beginning. This is where you are asking yourself, what are the objectives of your CLM? What is it that you're going to focus on? Is your CLM only going to deal with malaria, as we have heard from Nigeria, or TB, as you have heard from DRC? Or is it going to deal with malaria, TB, and HIV? As John also highlighted, that these discussions are happening in different silos. If your intervention, CLM intervention, is going to be HIV focused, are you going to look at issues of PMTCT as well as issues affecting PLHIV, as well as issues affecting KP as part of one package in a specific location? Or are you going to have a variety of CLM interventions based on different objectives? So it's very clear that the objectives are well thought through and defined. Part of setting objectives is also defining your indicators. This is very important because the objectives and the indicators will also have an implication in terms of the frequency of collection of the information, as well as the modes of collecting that information, but I will come to that. At this point of planning and conceptualization, critical questions with respect to ethical clearance. Countries to collect information, especially related to service as well as patient data in some countries require ethical clearance. You need to ask yourself early on the onset, will you require this kind of clearance in your country? How quickly can you get it? That time factor, have you factored it in your implementation time frame? I remember in the course of doing this work, I think in Malawi as well as in Zambia, they had not factored this, and this resulted to some delays in the pilot that was being undertaken in those two countries by, I think it's by ITPC and the national partners. So these are some of the questions that must be well thought through. Frequency of not frequency, but are you going to start a pilot and then learn from it and then scale up? Year one, you're going to do one site, maybe one district, and then year two, you're going to move to another region, you know, and the multiple districts or facilities. Are you just going to focus on one provincial hospitals, or are you going to focus on a provincial hospital or a regional hospital and the satellite health facilities that feed into that regional facility? All these questions must be asked and answered during the design and conceptualization phase, because this is where the scope of your CLM will actually be defined, and the scope and the depth of your CLM design has implications, of course, in terms of the modes of data collection and the costing. But more important is, I think one of the countries that had started implementing CLM with Global Fund support in the grants, which are actually ending now, has actually a nationwide CLM intervention, and they had never done CLM, and it is paper-based, and they had never developed tools, and they went full blast nationwide in 2017, and they are still struggling in terms of refining and actually advocating for the desired changes that they want to see. So it's very good to, at this stage, also to ask yourself and bite what you can chew. Understand that, appreciate that if you're new at this, then you need to actually start small and grow. But if you are robust and experienced, and I think one of the very CLM savvy countries is Uganda, then you can actually be in a position to go upscale nationwide. Next phase is stakeholder analysis and engagement. CLM is a community-led initiative, but it doesn't work in isolation. This is because communities and beneficiaries and service users hold the duty bearers to account, as we saw in the definition by the Global Fund. Now, who are the duty bearers and service providers? Majority of the duty bearers and service providers are governments because of HSS health systems, which are mostly centralized through the public sector. But also we have service users from civil society, and all these need to be brought together and engaged so that they can have an appreciation of what CLM is, what kind of information will be generated. It is not about undermining any service provider, but it is a strategy that will actually seek to promote the access and quality of services. It's not about witch hunting John Becko if he's the director of a regional hospital, or Mulewa if he's the Minister of Health, but it's all about improving quality of services and access to services, and the issues of adaptability, accessibility, affordability of services provided. Stakeholder engagement is also very important because at the end of the day, you will actually need people who can actually consume the, consolidate the findings of the CLM, and actually take, like I said, I like saying, you take the message to the mountain. Basically, you need champions of CLM from the community, from the stakeholders, who will actually say that in health facility XYZ, this is what we found out, and we want you to change. So once you are able to engage your stakeholders, you can actually identify strategic champions and actually constitute them into a steering committee who will actually can play a critical role when it comes to advocating based on the evidence generated by the CLM mechanism that you have collected. And if you choose to have a steering committee as detailed in the guide, then it's very important to have very explicit terms of reference on the role of the CLM and how they are actually going to help take the findings of the mechanism and the advocacy a notch higher. The next phase is the data collection, analysis, and reporting. In brackets, you see there triangulation. And again, this is very, very important stage. It should have been well known at planning and conceptualization, that whether you will be paper-based or you will be 100% electronic, or whether you will employ a combination of paper-based and electronic, or if you use Google Forms. At this stage also is very important to define frequency of reporting. I think it was from either Nigeria or DRC. I think it was DRC who said data collection was for a period of 6 months, when he said not 2020, but 2019. 6 months, that was from July to December 2019. So that's a whole period of data collection, and then now you go to analysis and reporting. So what is your frequency going to be like? Is it going to be quarterly? Is it going to be 6 monthly? Or is it going to be annual? What is recommended in terms of data collection, analysis, and reporting? It's because our primary objective is to advocate for corrective action, remedial action, which will then improve access and quality of services. So don't take long. 3 to 6 months is reasonable time. But if, for example, your data collection period is 6 months and emerging issues come within a month or two, then your mechanism should allow for flexibility for interim remedial action, advocacy, and remedial action to be undertaken. Part of the design stage should also invest in defining the type of reporting that you will be doing. Ideally, the outputs of CLM are primarily for advocacy for change. So advocacy materials are normally very precise documents. I like the advocacy materials from IPTC. If I can use the word, they are sexy in terms of the graphics, the colors, the layout, and the information there is on point with the evidence that is required. And it's very easy to put in a case and convince somebody on why the change is needed and what is the downside of having that problem as far as access and quality and saving lives is concerned. So it's very important from the beginning, you know the type of reports that you will be generating and the frequency of reporting and also the consumption. I think we have heard from Nigeria how they're engaging with mass media. So that is very important. As you can see, there's a razor thin line from reporting, you go to advocacy and influencing. So how are you going now to translate your report into advocacy and into an advocacy pack with explicit advocacy messages, explicit advocacy flyers, explicit advocacy one pages or 2 pages or 4 pages, which can then be used by the steering committee, or which can then be used by the delegation, for example, which will go to the health management committee of the hospital or the county health committee or the district health committee to say this is not happening well, and it needs to change in order to result to improved service delivery. Next is the follow-up, monitoring and closure phase. Now, assuming our CLM has identified 2 issues, and I want to pick 2 issues from one of the countries that I have worked a lot, is maybe there are recurrent stockouts in commodity stockouts, both HIV and TB, and there is also there are no insufficient mosquito nets, especially during the rainy season that is ongoing. So those are the issues that the CLM has identified as key priorities. And you have engaged at various levels, and at various levels, you've been told that the remedial action will be undertaken within the next 6 to 8 weeks at most. So part of following up from the CLM is actually to find out this remedial action which was promised. Is it actually taking place? Has it started? Is it ongoing, or is it yet to start? That is part of follow-up. So that if it is starting, well and good. If it has not started, then you actually do follow-up actions and say you promised that you will do in 6 to 8 weeks. It's now week 4, nothing has started. The children still don't have their diagnostics. The women don't have their PMTCT. So that you raise these issues so that the action can come sooner rather than later. And then once an issue is resolved at that point in time, the issue can be resolved today and it can recur tomorrow, or it can recur after 1 month. But once a particular issue is closed, then you actually bring that specific issue to a closure, and you can actually recognize and acknowledge, even with a thank you note, the relevant actors who are proactive in correcting that situation, and say, thank you, this was observed, this has changed, the children are now happy, the women are accessing, the KPs are happy, are getting their loops, one-stop shop, and we look forward to a continued collaboration, so that they actually see the value of CLM. And like John says, a lot of CLM is funded by grants, almost the last, and when it comes to an end, then you actually need to evaluate and learn from this initiative so that you can now choose to scale, or you can say you downsize, or you can, you basically learn and build on lessons learned. And again, going back to IPTC, I think there's an evaluation report which has come out. It's a good example of the review phase. It's actually evaluation and review, but it's of the mechanism in totality. Next, which I won't spend a lot of time in, I'll just go straight to the hyperlink. Where are you? And it's really straightforward. It's the costing of the CLM. As you will see, the costing of CLM is purely guided by the other 8 steps. This is step 9, but before then there were 8 steps. So there was the community empowerment and orientation phase. So you need to provide for meeting costs, and even if necessary, somebody to actually explain and empower all the stakeholders in terms of what CLM is all about. And then there is the planning and conceptualization. This is a process, like we said in the beginning. It is not. It's an inclusive process which has to bring all the stakeholders depending on the objectives of your CLM. If your CLM is KP specific, like what PEPFAR is supporting, KP specific or PLHFV specific, then the people who will be engaged in planning and conceptualization will be population specific. But if it is multiple disease or multiple populations, again, all the stakeholders. But what is very important is that service users and beneficiaries. need to be part of this conceptualization and design, as well as a few technical people, in order to have a robust discussion and to cover all aspects. And then in terms of what are some of the human resources, I think there's this type of question in the chat box. It depends again on the scope of the scope of your CLM mechanism, but you can provide for a coordinator, support officers, M&E. You also need to provide for internet and IT, as well as depending on the scope of your mechanism, you also need to provide for stipends for data collectors. It is very important to reward people who are engaged. It's very sad sometimes you go to the field, you find people are rewarded at different levels, even as a consultant you're paid, but the data collector, who is a member of the community, who is a service user, is expected to do so much and not rewarded even for transport, airtime, and a number of things. Stakeholder mapping and engagement. I think that one we talked about. The steering committee meetings, if you have one, if your steering committee will meet quarterly or after every 6 months, then you provide. One thing I forgot to bring out during this stage is also it's very important to launch your CLM activity, but now we are in the era of virtual launching like today, so but you need to make provisions for inputs.
Yeah, we need to move towards
capacity building, data collection and analysis. So the costing is actually correlated with the 8-step graphic that I showed you earlier. Data collection, influencing, there's an advocacy budget for dissemination of reports, for face-to-face meetings, for follow-up, and then the reviews, and then the annual reviews, and then TA and end of project evaluation. So this is just a guide. It can be adapted to suit your specific context. And I think I will stop there. The rest is.
Thank you very much, Rhoda, and thank you to all participants who have been here. There are quite a lot of interest on the CLM guide. If you look at the chat box, there are quite a lot of questions that actually needs to be responded to. And if we actually said that we wanted to do that right now quickly in 2 or 3 minutes, we'll be doing a disservice to the so much interest that people have on CLM. And on this regard, we are actually thinking we will actually do another webinar to focus on exactly the issues that people have raised up, so that we can have some good time to digest them and reflect on these issues. Meanwhile, we will actually try as well also to respond to all these issues that have been put, and then we'll email the responses to individual participants. So at this particular point in time, I think we need now to move to our last stage of this webinar, where we are actually going to be doing our virtual launch of the CLM guide. But just before we run a clip, I will just want to welcome frontline aides to do a quick remarks, and then we will have Kiva to also do some remarks, and then we will welcome Olive to actually do the virtual launch of the guide. So if we can have frontline aides, Enrique, please, to just give us a few remarks.
Well, thank you very much. I'm not very sure about the timing. I don't know when we're finishing this webinar. I don't want to take too much of anybody's time, so I will be very quick if I can. So thank you very much for letting me intervene on behalf of Frontline Aides. Our partnership is made of civil society organizations and community-based organizations working in over 35 countries. And much of the work that we carry out together involves developing aspects of community-led monitoring described in the guide. For example, community-led and owned human rights monitoring and response systems like REACT, peer-to-peer technical assistance on community-led monitoring for civil society organizations, but also for country coordination mechanisms of the Global Fund, and through community-led programs involving research, data collection, and M&E. There's been a lot of wisdom and expertise explained in this webinar. Thank you very much for all the examples and for the description of the guide. I would like just to mention two things that are important to reflect on, and I think they've been mentioned somehow by some of the interveners. The first one is how important it is to make sure that it is understood that community-led monitoring is part of the overall community response to health. I think Keith really mentioned community systems strengthening. For us, it is very important that donors and other supporters and stakeholders and governments understand that community-led monitoring is essential, and it's also an essential part of an interconnected contribution that communities make to the HIV, TB, and malaria responses, and that they just don't settle for community-led monitoring without the connection with the service provision that communities provide, the advocacy, the campaigning and participation in accountability. Community-led monitoring is just left on its own. The second thing I just wanted to mention and to maybe highlight is that community-led monitoring can be part of the national response to health. And I think embedding community-led monitoring in the bigger framework of national responses to health is a way of following the ambition that the guide really sets out in terms of thinking big and scaling up the response. I'll give you the example of civil society in South Africa or Senegal, or Côte d'Ivoire, which are embedding the Riyadh human rights monitoring system within the larger M&E system of the national response. Obviously, this has the potential of getting quicker institutional responses to human rights barriers and to absorb evidence that is less contested because it comes from within the system that the government and other institutions are using. I do realize that this is risky as well, because of the risk of data, especially from marginalized populations being shared elsewhere. But the good news is that now we have the community and the expertise, we have the expertise and the technology at the community level to control, to own the data, to own which data is used and or shared with other actors. And this is very important. Bottom line is that community-led means community owns data and total independence to decide how to use and share our data. And at the bottom line is that what we really want is to increase accountability and to improve the access of community members to health services and the full realization of the human rights. So this guide is going to be a great tool in that respect. So thank you very much. Over to you, Onesimus.
Thank you very much. Thank you very much for those really well crafted remarks and quite insightful thoughts on community-led monitoring. Thank you very much. I would now wish to welcome Kiva to also give us some remarks. Kiva, welcome.
Thank you, Mloya. Can you hear me?
Yes, very loud and clear.
Fantastic. So good afternoon, friends and colleagues, and thank you to all the previous speakers as well. As a representative of a technical partner, I'm very much appreciated the reflections from John on the role of technical partners to ensure that CLM remains genuinely community-led and driven. It's really an important point for us to remember and to act upon, so thank you for that. So on behalf of the Stop2B partnership, we really wanted to sincerely thank and congratulate ENASO and Frontline AIDS, GIZ Global Fund, and all the implementing community-led monitoring experts from across the globe who contributed to this guide. It really was a privilege and an honor for the Stop2B partnership to provide a level of technical assistance towards its development, because many of you will know community-led monitoring is really a central intervention in the Stop2B partnership human rights portfolio of work, because the protection and promotion of human rights are not only the foundational principles of CLM, but they're also an objective and a goal of CLM in and of itself. So as such, we are really pushing hard so we can promote CLM in all of its diversity, creativity, and effectiveness in order to transform the TB response TB rights-based, people-centered, community-led and driven, as we've heard, which is a key commitment within the UN Political Declaration on TB. So from our perspective, this guide is evidence-based, given all of the work and experiences community and civil society who've been doing in CLM, as was mentioned by Salome and Rhoda. And it's timely because we see that there's more and more interest from the donor community in this work, and it's practical as it gives and walks community and civil society and all of us, in fact, through the process on how to design and scale up CLM effectively. So in Stop TB, thanks to the support that we received from the Global Fund through the strategic initiative to find the missing people with TB, with co-financing from USAID, we were able to explore supporting our civil society and community colleagues from across the globe, like the likes of Stop TB Partnership Tajikistan, TB People in Ukraine, CANA in Cambodia, LKNU in Indonesia, ADBP in Mozambique, IANASO in Tanzania, Club des Amis d'Amiens DRC, to do this work. And so to support this work through the work of our partners, we developed what we call a CLM framework and this digital platform called One Impact that Maxime spoke about. And I think for those of us engaged in its pursuit, especially our civil society and community colleagues, I think we would probably all agree that it was a huge learning experience over the past 3 to 4 years with many twists and turns, which ultimately led us to believe more and more and more in the power of CLM to advance a human rights-based approach to TB. So to continue as a technical partner to support this work, we are revising the CLM framework based on, and with the support of ITPC Global, based on experiences from countries. We're updating the One Impact tool based on experiences from countries. We're making the source code available based on requests for full ownership of the platform. And so all of these materials will be available by the end of this year, which can be adapted and used in any field of health, irrespective of whether it's TB, malaria, or combination, HIV, and so on and so forth. So I'm really pleased to say that we're also supporting and working alongside the Global Funds and Keith on the CLM initiative with Gemma and Caitlin and others in the CRG department. And finally, I just wanted to announce that we will be announcing another round of the Challenge Facility. The plan is to do so either by the end of this year or by the beginning of next year. So the Challenge Facility for Civil Societies is a grant mechanism for community and civil society to advance a rights-based approach to TB. So in other words, there will be opportunity to advance CLM in TB or a combination of TB, HIV, and malaria, and whatever is fitting for your country's context. So on that note, I once again want to congratulate IANASO, Frontline AIDS, GIZ, Global Fund, and you all, and an excellent, excellent, excellent guide. And thank you for collaborating, for your collaboration on this.
Thank you so much. Thank you so much, Kiva, for those very warm and encouraging words. So before I finally call in Enrique again to give the final vote of thanks, I wish to welcome Olive, so that she can lead us actually to the launch of this guide. Olive, welcome.
Thank you very much, Mlewa. Apologies, I think the webinar has taken longer than what we thought, so we are over time. We apologize for that. But just to say, in terms of the guide itself, we are very happy that now we have a document that can be utilized as communities integrate community-led monitoring into the Global Fund processes. The guide, which is being shown on our screen, is around 40 pages, but we have a popular version which is around 6 pages, and the link has been shared on the chat box, within the chat box, and we will also be sharing it as part of the other presentations. What I also wanted to say is GIZ Backup will be supporting the translation of the guide into French, into Portuguese, and into Spanish by the end of the year. So be expecting that as well. Today, we've not been able to finalize in terms of the questions, and time is not on our side. So we are thinking of having a follow-up webinar which will address specifically the questions and any other comments and discussions that we need to have. With that, I would like to say thank you so much. But before we do that, as part of our launch, we have a short video. Glory, I hope you're hearing me. We have a short video that we wanted you to listen. And then soon after the short video, we will have Enrique to give vote of thanks. On my side, as part of VIANASO, I would like to just appreciate each and every person that has been involved, and we'll hear more when Enrique gives the vote of thanks, who those individuals and organizations are. So let us just listen to the video. Thank you so much. Over to you, Glory. There's no sound.
Rodrigo, no sound.
Unmute mic.
Okay, because of time, what we will do is we will share this alongside the presentations so that we don't waste more time. Mlewa, let us move on. Thank you.
Thank you very much. Thank you very much, Olive. So is Sophie back, Olive, or is Sophie still out? We could actually hear from Sophie before Enrique gives us the final closing remarks.
From GIZ, there was an apology. They had to leave early. I think there was a meeting that is happening, but they are very happy to have been part of the process. And Sophie and the GIZ backup team expressed their profound gratitude for the team that has put this together. So Sophie, unfortunately, is not with us here. Thanks.
Oh, thank you very much, Olive. So in concluding this, I want to welcome Frontline Aids again to just give us the vote of thanks before we close. Welcome.
Yeah, thank you very much. Thank you, Nesmus. Thank you very much, Olive. And perhaps if the video is sorted, maybe after my votes of thanks, it can be played again. So this is a bit formal, but I don't want to make it formal because it's been such an incredibly engaging and lively webinar. No, but I need to say thanks on behalf of VIANASO, GIZ Backup, Stop TB Partnership, and Frontline AIDS. We would like to acknowledge first and foremost the community contributors from the six countries in the guide. I wanted to mention them all because this is important, very, very important in a community-led monitoring guide. Unfortunately, there's so many, it's just impossible. We'll take the entire half an hour, I think. But they are all named in the guide. They are our partners, our community contributors from DRC, Malawi, Sierra Leone, Tanzania, Uganda, and Zambia. We thank you all for sharing your valuable and diverse experiences, which greatly informed the developments of the guide. We would also like to pay special thanks to the community of peer reviewers of the guide and acknowledge the technical advice and leadership received from UNAIDS, Stop TB Partnership, GIZ Backup, and the Global Fund's Community Rights and Gender Strategic Initiative team. Also, special appreciation to you, Rhoda Leva, and her associate, Salome Atim, for your dedication and your commitment to developing the guide. And VIANASO and Frontline Aids would like to acknowledge, I know they're not here, but we would like to acknowledge the financial support and technical support received from Backup, from GIZ Backup, which made possible the development of the guide and the translation into several languages. And lastly, personally, we would like to thank VIANASO for the leadership and determination to ensure that civil society and communities have the tool to ensure meaningful engagement, strengthen existing capacities, and ensure community ownership. So thank you so much, VIANASO, for your incredible leadership in this project. Thank you.
Thank you very much. Thank you very much. I think this has been good, guys, and I have no more words to put after the closing remarks have actually been spoken. This is the end of our webinar. We will organize actually another webinar. We have seen the interest on this so that we can have more time to probably go with the guide and further discussions. Thank you very much, everybody. Have a nice evening. Take care wherever you are, and we'll share the video so that you can enjoy it.
Thank you. Thank you, everybody.
Thank you all. Thank you all. Congratulations.
Thank you,
you.
everyone.
Thank you, everybody.
Don't miss the follow-up webinar. Bye.
Definitely not.
Bye. Thank you.
Bye from Uganda. Bye. Thanks.
Muito obrigado.
Bye-bye from Malawi.
Thank you from Zambia. And
thank you from Zambia. Bye.
Thank you from Tanzania. Bye.
Thank
Bye
you
from Tanzania.
Bye.
Bye from Nigeria.
Thank you. Goodbye. From Nigeria. Bye-bye.
Framework for civil society organizations to be able to embed and develop community-led monitoring. My name is Onesmus Mlewa Kalama. I work for INASO, which is a regional organization based in Arusha, Tanzania. INASO coordinates community action and supports communities to engage in national and global fund processes. For this reason, we developed a community-led monitoring guide to provide a framework for civil society organizations to be able to embed and develop community-led monitoring systems to generate information that will be used to inform programming as well as advocacy for decision-making at both national and regional levels. This community-led monitoring guide is going to provide a framework upon which civil society organizations and community groups will be able to implement community-led monitoring systems to generate credible information that they can actually be able to use to inform their programs, to hold leaders into accountable, as well as ensuring that they have information that they can use for advocacy in decision-making process.
My name is Tambazai Magwenzi, the Her Voice Fund Ambassador for Zimbabwe. Why is it key that communities should gather information? I believe that information is power, and communities should gather information because there is the strengthening of data advocacy-driven work. Resulting analysis of information can impact positive changes in communities. Communities should gather information in a systematic monitoring model, which ensures that there is the elimination of stigma and discrimination. But this would enable a culture of collective problem solving amongst decision makers, healthcare workers, policymakers in health, and also the recipients of care in HIV services.
My name is Aaron Sunday. I'm the Executive Director of African Network of Adolescents and Young Person Development, and I base in Nigeria. Why community should be at the center of community-led monitoring is due to the following few reasons. One, it will help in terms of improving quality of care for the committee members. Secondly, it will help us in terms of generating evidence, data that can be used in terms of advocacy. Thirdly, it could help in generating meaningful data that can be used in terms of designing programs and intervention. Fourthly, it's going to help us in terms of accountability, both from the health sector perspective and also from the government perspective to ensure services are delivered to the minimum standard.
I am Martha Clara Nakato, and I work with Uganda Network of Young People living with HIV, UNIPA. Community-led monitoring gives the community the power to take part in influencing the strengthening of robust and effective health systems that we want. It is important to note that community data does drive the implementation of strategies for improved HIV/AIDS related SRH, but also importantly, healthcare service provision. And that is why community-led monitoring remains very, very important for the communities.
We wish to thank our partners who supported the development of this guide in various forms, GIZ, Backup, and Frontline Aid, for their support in technical and financial support. We also would wish to thank Stop PV Partnership, the Global Fund Community Rights and Gender Strategic Initiative Department for having provided their technical support in the review of this guideline. We would wish to also send our thankful recommendations to all community members who are involved in providing essential content for the development of these guidelines. We also would wish to thank our consultant, Rhoda Lewa, who pulled all the information together to have this useful guide today. And many other partners that I am not mentioning here today. You are all gratefully thanked for having spent your time to actually contribute in one way or the other to making this guide the way it is today. As we launch this guide today, we wish to welcome all communities to be able to make use of this useful resource. Use this guide to shape your community-led monitoring systems so that it can inform your programs that are going to change the lives of communities.